each year in Los Angeles alone. NCJW LA offers a variety of programs and services. Currently, our Women Helping Women program is accepting applications for the second scholarship cycle. The deadline is November the 1st, 2012. They're also accepting referrals of, for the individual, couple, and family therapy waitlist and support groups, which will begin in late September and early October. And volunteers are needed to help with holiday gift solicitation, assembly, and distribution. NCJW LA is pleased to present our second annual Jewish Women's Conference of Southern California on Sunday, November the 11th, 2012 at UCLA's Cobble Commons from 8:30 a.m. to 6 p.m. The keynote speakers, Christine Pelosi and Hannah Rosenthal, and our panelists will be speaking on topics of feminism in today's society, confronting the economic status of women in Southern California, and Jewish women's voices in activism. Also, NCJW LA is co-sponsoring Celebrating Women's Equality Day 2012, which will be on Friday, August 24th, 2012, between 8 a.m. and 10 a.m. There's more flyers in the back and information for you if you're interested. In fact, all our events have flyers in the back, or you can call go online or ask Ruth Williams, who is wandering around here somewhere. And the Advocacy Committee would like to invite you to attend the exciting upcoming events. Women to Women, focusing on issues in the lesbian community, will be held on September the 12th at 11:30 a.m. to 1:30 p.m. Panelists will include the LAP Lieutenant in charge of the Special Assault Section, and Lori Jean, the CEO of the LA Gay and Lesbian Center. And the documentary film Invisible War about abuse of women in the military will be shown on October 11th at 6:30 p.m. The director of the film, Amy Ziri, will be here to answer questions afterwards. If you want any more information, please feel free to look at the back or ask Ruth Williams, who's standing back there. Ruth, acknowledge yourself. In the packet of information on your chair, there is a yellow evaluation form. Please complete this form and return it to us at the end of the meeting. Evaluations are used to plan for future programs. The blank cards in the packet are for questions you may have. Write your questions, hold up the card, somebody will pick them up and give them to our moderator. And bios of each of the moderator and each panelist are included in your packets. Unfortunately, due to the California State Legislature's work on the Affordable Care Act, Janice Rocco was unable to get down here today. I'm privileged to have put together such a dynamic panel to discuss the Affordable Care Act. I have spent my entire adult life working in some capacity in healthcare, and I am really interested in what our panelists have to say. Therefore, it's my great honor for me to introduce you to our moderator, Michael Hiltzik. Michael has been a panelist at NCJW in the past, and we are thrilled that he was willing to be involved today. He is a Pulitzer Prize-winning journalist and author who has written about business, technology, and public policy for the LA Times for 3 decades. He has written numerous books and has won a number of literary prizes. Michael's latest book, The New Deal, A Modern History, was published in September of 2011. His book, Colossus, Hoover Dam and the Making of the American Century, was a New York Times bestseller. A graduate of Colgate University and Columbia University, he lives in Southern California with his wife and 2 sons. And Michael, I will let you take it. Is that not working?
Okay, now I think it's working. I've been just deprived of my microphone, so I'm going to steal one for the moment. Donna, thank you very much for that introduction. And thanks to all of you for joining me in this outstanding panel for a comprehensive discussion this afternoon of the Patient Protection and Affordable Care Act, or to use the label that was originally coined by Republicans and has since been embraced by the administration, Obamacare. Obviously, if we had come together, we're going to find one that works. Obviously, if we had come together for this discussion, even just a little over 3 weeks ago, that is to say, before the Supreme Court's ruling on the Act, our discussion would have been very different. It would have been much more conditional, and for you grammarians in the audience, we would all be talking in the subjunctive. And of course, if Chief Justice John Roberts hadn't executed his fine legalistic pirouette on June 28th, the discussion would have been very, very different. Or was it July 28th? I can't remember. But the court upheld the Act, and it's now become a certified fact of life for all of our panelists this afternoon, and indeed for all of you too. And I think what's also interesting is that in the context of the presidential campaign, you don't hear from Republicans as much as you used to about their plans for repealing Obamacare or repealing and replacing Obamacare. And you don't see Democrats running away from the Act as much as they did during the 2010 campaign. Now, that may be because for weeks now we've been tied up in a discussion of which side is out to kill Medicare and by how much, or why a multimillionaire private equity investor is paying a federal income tax rate of only 13%, or the definition of legitimate rape versus illegitimate rape, and the medical implications of each of those forms of rape in Fantasyland. But surely the Supreme Court decision has underscored how difficult it would be, and always would have been, to repeal what is, in my view, the most far-reaching package of progressive social legislation that we've seen enacted in this country since the 1930s. Now, you all have biographies of our panelists at your seats, so to save time, I'm going to skip over the details of their very distinguished credentials and quickly point out the aspects of healthcare delivery that they may best be able to focus on as we continue the discussion this afternoon. The effects of healthcare reform can't easily be pigeonholed, however, so I expect we're going to learn a lot about how all the elements of healthcare delivery interact with each other and with the Affordable Care Act. So, just to start the introductions once again very briefly, to my immediate left, Dr. Paul Song is a board-certified oncologist at Cedars and a board member of Physicians for a National Health Program, California. His organization has been a leading, or I might say the leading, advocate for single-payer health insurance in the U.S. So he may have important thoughts for us on how the ACA and the court decision will affect what is, I assume, the continuing push for single-payer, which is what most health economists see, or many health economists see, as the most efficient and effective way of providing health care. And of course, as a practicing oncologist, I think he can also give us a view of the ACA from the standpoint of a provider. To his left is Mark Peterson, professor of public policy, political science, and law at UCLA. Can, I hope, give us a window into how the Affordable Care Act came together in Congress, what lies ahead in the policymaking sphere, not only nationally, but especially here in California, since Janice is not going to be with us. And of course, that's important because California, up to this point, has been a model in the implementation of the ACA at the state level thus far. To my immediate right, Susan Burke-Fogel, Director of the Reproductive Health and Justice Programs at the National Health Law Program, can, I hope, talk about how the Act will affect Medicaid and its providers and beneficiaries, and as well talk a little bit about the Medicaid aspect of the Supreme Court ruling, which some people may say may be even more important than its ruling on the individual mandate. And Susan, I think, is well placed to also talk about the effect of the ACA on women's health and women's reproductive health. To her right, Jim Lott, Executive VP of the Hospital Association of Southern California, is, of course, in a great position to tell us how the Act is going to affect the operations and finances, and, well, the health this major segment of the healthcare delivery system in the United States. Now, as I said, these are all sort of foundational themes for our panelists to discuss, not limitations on what I'd like them to talk about. So why don't we start by having each of them talk for, say, 5 minutes or so on a generalized view from where they stand on the Affordable Care Act and what the healthcare landscape looks at from their windows on the world, and then we'll continue the debate and discussion from there. You each have at your chairs cards on which you can write questions, and I would encourage you to write questions as the discussion proceeds, and then they will be brought up to me, and while we're all talking and debating, we'll be able to interject your concerns, your views, and your comments from the audience. So Paul, why don't you kick it off and start?
Well, I want to thank you all for allowing me to come and be part of this great panel. And first, I just want to give you a caveat. I consider myself a progressive, and I am working very hard to see the president get reelected. But having said that, some of the words I'm about to say may seem a little bit harsh, but this is the truth. So I am a physician. I've been in practice since 1995. And one of the things when I first graduated from medical school back in 1991, which was over 20 years ago, hard to believe, was that we raised our hand and we took the Hippocratic Oath. And one of the things that really stood out to me was there was a statement that said, "I will follow that system of regimen which, according to my ability and judgment, I consider for the benefit of my patients, and abstain from whatever is deleterious and mischievous." Over the last 20 years, the current healthcare system has been deleterious and mischievous. 35,000 people die each year in the United States simply because they don't have health insurance. And for all the people that claim to be pro-life, it's really hypocritical that they don't seem to care about, once you're born, the life that you have. Just to give you a little bit of history, because I don't think it'll be framed, but then how did we get to where we are and why I have some problems with this. So in California alone, health premiums have increased 52% in the last 7 years, where the average salary in the state of California has only gone up 4%. 35,000 people, as I mentioned, die in the U.S. simply because they don't have health insurance. The number of medical-related bankruptcies has increased 50% in the last 9 years. 2/3 of nearly 4 million bankruptcies last year were medical-related, and 75% of those people who actually had medical-related bankruptcies actually had health insurance. How is that supposed to happen in our country? The Commonwealth Fund just released a study that showed in 2010, 51% of women under the 133% of poverty level were uninsured. So when we look about, we're going to talk about Medicaid expansion, that's really important to know, because this is 51% of all women in that group are currently uninsured. So we had all these problems, and we're already spending $2.5 trillion a year as a country on healthcare. That's by far almost 2 times as much as any other industrialized nation in the world, and yet we have 51 million uninsured. So fast forward, President Obama took it upon himself, expended a lot of political capital to really go after a crowning legislative achievement, which Michael had pointed out. The problem was that during this process, unlike President Clinton, who was accused of doing things behind closed doors when he tried to do healthcare reform, he gave it to Congress, and he basically gave them some rough guidelines on what to do. Well, the problem was during this whole thing, there were 3,300 healthcare lobbyists for the 535 members of Congress. They were spending $1.2 million a day, more than what was spent on the entire Bush-Kerry election, to craft legislation. What was really interesting, of those 3,300 registered lobbyists, 450 of them were former congressional staffers. You hear about the revolving door. And 12 were former Max Baucus staffers. Now, you remember what happened where was this legislation held up for a long period of time when Ted Kennedy passed away? It was Senator Baucus. So it's no wonder that this bill looks like, in large part, it was written by the private insurance industry. So what did we get for this? At best, I applaud the president, but at best, the Affordable Care Act, according to a recent Congressional Budget Office estimate, will leave 30 million people uninsured by 2022. So when you look about, you hear about the uninsured and the cost, they go into the emergency rooms, don't get paid care, and that ultimately drives up our premiums. This is still going to be a persistent problem. Another 40 million will be underinsured and therefore at risk of financial ruin or death if they get seriously sick. As I mentioned, this is a $450 billion gift to the private insurance industry that forces 30 million of us to buy a product from an industry that only profits when they deny care. So the idea that we're putting these people as the gatekeepers or as the key to a pivotal legislation is a major problem. And we'll get into other specifics in a minute, but I just want to set the table, and I'm sorry to depress you all with what we've got, and others will talk about the good parts about the Affordable Care Act, and there certainly are. But I do think that that was really crucial to understand where we are right now. So when I see Democratic legislators get up and say that they've gotten universal health care, this is not universal health care. Remember all the undocumented immigrants that are not covered under this, that are still going to impact each in our insurance rates. The last thing I want to just say is that in the last 10 years, the average insurance industry, the top 10 insurance industry profits have gone up 450%. It is the only recession-proof industry other than the military-industrial complex of the last 10 years. In a downward recession, you would expect the cost of everything to basically come down, but their prices have gone up. And I would just say that that is the fundamental basis of this insurance Affordable Care Act. Mark?
Thank you, and like Paul, I'm very happy to be here, delighted at the invitation, both because of a wonderful audience and a terrific panel to get to know. Let me say a couple different things. One, I'm a political scientist by training, and I study and write about, in particular, the politics of the presidency, Congress, interest groups, and healthcare. And one way to think about how we got here is to ask, did we ever try to reform the system before? And of course we did. There's a stunning number of people who don't know that, by the way. They think this was the first time anybody ever actually tried to do healthcare reform. First effort really was a discussion that grew out of the American Association of Labor Legislation in the Progressive era, 1912 in particular, Teddy Roosevelt coming back as a bold new presidential candidate, unhappy with his hand-picked successor, ran with the notion of borrowing from Europe the idea of sickness funds. Well, between 1912 and this latest round in the Obama era, we had the Truman National Health Insurance, single payer. We had the Nixon pay-or-play, employer mandate version of healthcare reform. We had the Jimmy Carter version. We had the Bill Clinton version of health alliances. And a lot of this occupied an enormous amount of public debate and congressional time. And guess what? There was never a single vote in Congress, in the House or the Senate, on healthcare reform during any of those periods. This is the first time there was actually a vote, and the first time something actually passed. Now, why the version? Obama during the campaign, Senator Obama during the campaign, admitted that if he could do things from scratch, he'd write a single payer plan. He's a very wise guy. So would I. And I did participate in writing a single-payer version of healthcare reform in the early 1990s when I worked in the Senate. But I also, my first faculty appointment was at Harvard, and I taught a junior seminar on the politics of healthcare reform. And there was a very earnest, very bright young fellow in that seminar named Jacob Hacker. You may have heard him on the radio and seen him on television. Jacob's become a real force in the politics of healthcare. And he wrote a piece for, I think it was for Health Affairs, which was, before this latest round, was essentially put politics first. That if you actually want to get it to a vote, if you actually want to pass something, in particular if you want something that's going to get 60 votes in the Senate, which is now the requirement for doing anything other than taking out the trash, you're going to have to figure out how to do the politics first. And so Obama and the Democrats decided, well, why don't we try to build a bipartisan coalition by taking the ideas from Republicans? Individual mandate, which had come out of Stu Butler, terrifically smart guy at the Heritage Foundation, and had been in a Republican plan in the 1990s in the Senate. Let's do insurance exchanges, which had also come out of Republican plans, or also were part of the Massachusetts plan that Governor Romney had passed along with individual mandates. How about tax credits and subsidies to help people afford private insurance? Okay. So the Obama plan, the Obama Democrats plan, is actually the most Republican healthcare reform initiative that's ever been put forward by a president of the United States. Now, interestingly, the Republican Party has shifted so dramatically to the right, and I can give you all kinds of data to show that it turned out their ideas were no longer their ideas. And so, not the best foundation for a bipartisan plan that I think would be impossible. There is no such thing right now in healthcare reform. But it did create the opportunity to hold on to people like Ben Nelson from Nebraska, so the Democrats would actually have 60 votes in the Senate for the first time to be able to pass something over a filibuster. That was the simple political calculus with a lot of compromises along the way. The other political calculus was Bill Clinton took on the insurance industry and the pharmaceutical industry, as did all prior Democrats, and they put all their resources into defeating healthcare reform. This time Obama tried to side up with the insurance industry and the pharmaceutical industry, and they bought ads in favor of healthcare reform. Another reason why this thing passed, which I think overall is for the good, and we can have an interesting discussion about whether or not it is. Now that said, we're now in the implementation stage, and I've been asked to do a number of things here, so let me just take a moment. We're now into building the state health insurance exchanges. Well, we are doing that in roughly about 16 states. The Republicans took control of in 2010 in particular have been long delayed because they thought they were going to be able to kill this thing in the court. They're still hoping to be able to kill this through the election process, and so they've just chosen not to create exchanges, which ironically may mean they're going to get a national exchange set up by the Department of Health and Human Services and the Obama administration. California, I don't really have that much to say about except to say it's always been ahead of everybody. It's led on this even before the ACA passed. It's got a bipartisan commission of very bright, capable people working to create the exchange dynamic. I have tremendous confidence in the capacity of the state to do this better than anybody else. There will be a few, obviously Massachusetts already has an exchange. There will be a few others like Connecticut and Minnesota and some of the more progressive states around the country who are advancing. But that is going forward. But the big interesting question will be what happens in all those states that are choosing not to do the exchanges, and how are they going to respond once they get a nationally developed one. But I want to take a few moments at least, and Michael cut me off at the arm when necessary, to talk about something that nobody talks about. And that is that the Affordable Care Act is a lot more than just insurance. It's a lot more than just insurance. You know, 75% of the healthcare costs in the country come from chronic disease. One of the problems facing Medicare in the future is there's been a 20 percentage point increase in the number of beneficiaries who have 5 or more chronic conditions, and that accounts for about 75% of the increase in costs over the last 10, 20 years. We have a healthcare system that's broken, and we have a health system that's broken. I was part of a Blue Sky Health initiative, which was has been designed to try to transform fundamentally the health and healthcare system in the United States. And we got very involved in, to some extent, working with people on the Senate Education, Labor, and Pensions Committee and on the Finance Committee to help draft parts of it that have to do with preventive care. Title IV of the ACA is all about preventive care, prevention of chronic disease and improving public health. It creates a National Prevention Council to develop for the first time in the United States a national prevention strategy. And it's about 17 different federal agencies, both obviously healthcare agencies, but also not normally thought of as healthcare agencies, coming together to think about how one improves health. It includes a fund for prevention and public health. $15 billion was to be allocated to that over 10 years. The first time there would be stable, sustained funding for public health infrastructure and population health initiatives. It includes funding for community transformation grants to help communities design programs to take on issues of population health, health disease, lung disease, tobacco, obesity, diabetes, a whole range of issues. Considerable amounts of funding. Unfortunately, $5 billion of the fund for prevention and public health was used by Obama and Congress to help pay for the payroll tax holiday. When you put money on the table, people like to go after it. And there are a lot of other initiatives that are there are two kinds. One kind you might call clinical prevention. What we do when people come into a healthcare facility, whether it's doctor, nurse practitioner, or community health center, for screening for cancer and various other things. That tends to improve health, but also increase costs. Because anytime you bring anybody into the medical industrial complex, you are bound to create a more expensive enterprise. But it improves health. Another big part, and this fund is about it, and community transformative grants are about it, and all kinds of other things in the Act about it, are about transforming population health, shifting the health curve for whole populations. Knowing that only about 10% of mortality and morbidity is actually a function of health care. The rest of it comes from the environment, genetics, and behavior. And if we don't tackle that, and this was a bipartisan issue in the 2008 presidential election, by the way, if we don't tackle that, then we're just going to continue feeding the healthcare system with people who are spending their lives getting sick. Not only that, as part of Blue Sky Health, is the whole notion that you have a life course development. If you deal with problems in utero, then you put people on a higher health trajectory when they're born. If you continue to do that for the early ages of childhood, you continue to raise their health status trajectory and reduce the number of times and the amount of time they have to be in the medical system as they get older. A lot of heart disease we can trace back to what happened to kids in their neighborhoods when they were 3. And we're just being stupid if we don't deal with that. And this is an element that's in the ACA. It's an important element in the ACA. If the court had struck down the ACA over this insurance issue, we would have lost all that. And I just wanted to make sure, there are not many opportunities when we talk about the ACA to emphasize these issues, and be happy to talk more about that and everything else about the ACA as well.
Okay, thanks a lot, Mark. And we will be talking about a lot of these issues. Again, before I turn to my other two panelists, I just wanted to mention as an aside, since Mark mentioned Stuart Butler as the godfather, so to speak, of the individual mandate, Stuart Butler also is known in Social Security circles as the co-author of a manifesto that was known as the Leninist approach to Social Security and Medicare, and this is an article that was published in the Cato Journal in the 1980s. And what his idea was then that he offered to conservatives as a gift was that the way to undermine confidence in Social Security and Medicare to the point that you could get an electoral majority to overturn them was by guaranteeing elderly people, those who were near or already in the systems as recipients, that it wouldn't be changed for them, but that it would be changed for everybody under. This was going to be a way to capture the votes of seniors who do vote in favor of changing and cutting back benefits, because you'd be guaranteeing that it wouldn't happen to them. And I think we've seen as recently as the current election. And in fact, Stuart Butler, by the way, is a very close associate and advisor to Paul Ryan. So we can see that. Anyway, Jim, why don't you take it up from there and give us your view.
Okay, thank you very much. Let me say first that I can be really brief by referring you to
It's not
Let's see if this one works. Okay. If you all just make a note, the Wall Street Journal had an article dated December 12, 2011. And the title of the article was "The Future of U.S. Healthcare. What is a hospital, an insurer, even a doctor? All the lines in the industry are starting to blur." If you want to learn and appreciate what the ACA has done to change the future of the delivery system, I highly recommend that you read this 16-page article in the Wall Street Journal. They spent a good deal of time helping us understand in very readable terms about what you might expect to see done differently. Bottom line for hospitals. Now, hospital care, as you know, is about 31%, or accounts for about 31% of all healthcare expenditures in this country, and it's a large part of what the problem is. When you look at the triple-digit inflation for healthcare relative to, or the triple-time inflation for healthcare relative to overall inflation in this country. And a big part of the sell on the President and Congress's program was bringing or bending the cost curve, bringing the cost of healthcare down, and there were a number of initiatives to help do that, but that was a huge goal. And as a result of that, they've changed, or we have changed, the way the delivery system fundamentally operates, and we've done that through the way that we are financing the way healthcare is being done. Hospitals have always been paid based on things that we do to people. Heads in beds. We get paid for heads in beds today. That's changing. We're moving from heads in beds, or from volume to value. We're going to be paid based on how we contribute to the overall improvement in the health status of populations. We're going to be paid based on how we work well with providers who treat you before you come to a hospital, as well as providers who treat you after you leave for the hospital. We're going to be forced to do something we haven't done before, and it is talk to each other, communicate. We're going to have a medical record that is universal. It's not something we've had before. We're going to have providers who are at risk financially for being involved in the full spectrum from cradle to grave of the entire health. That is nothing short of a sea change. It is huge. And most of the insurance companies, the commercial insurance companies, are embracing that model now. Medicare is doing it through accountable care organizations and through bundled payments, things I don't want to explain to you. If you want to learn about that, go to Kaiser Family Foundation website and you can get all the information you want to know about what those things are. But understand that this is a fundamental shift in the way things are going, and the health care that you're going to receive in the future is going to be reflective of that. I will add 2 more points because I really want to get to the Q&A part of what this is all about. Before the ACA passed, the stimulus package that was an attempt to help turn the economy around included a provision in it that set up something called a comparative effectiveness panel. In fact, that's not the right name for this. There's a more correct name for this. But what it did was it set up this panel that's operating now that has people and a huge bureaucracy behind it that is going through or using supercomputers and scientists and the medical profession to amass data to determine for certain or specific treatment modalities, certain illnesses, what's the most effective treatment for you? It is an attempt to try and assist the medical profession in deciding what would be the appropriate care for you for a specific disease or a specific malady. Big change. People are afraid of this because this harkens to what cookbook medicine. Insurance companies are jumping on this bandwagon. Healthcare is changing, folks. Insurance companies are jumping on this wagon. One major insurance company in this country, Anthem Blue Cross, bought a computer system called Watson. I don't know if you heard of Watson. Watson is the best Jeopardy player you'll ever see. Watson also has the record, can beat any chess player in this country. Blue Cross said, why don't we amass all the knowledge that we have in medicine today and put it in Watson? And when the doctor or the medical professional calls to say, I got X one of your patients, and I want to do Y to that patient, they'll throw, well, doctor, give me the following data. Dump it into Watson, and Watson will come out and say, well, doctor, this is what the most appropriate thing for you to do. Okay? Now, I'm being alarmist, intentional, but I want you to understand these tools, these things are out there. Reducing the high cost side of healthcare, and this is the last thing I'll say, and move on to Susan, who will tell us some things that we need to understand about the Medicaid program and stuff that's going on. Hospital care is expensive. We have been experimenting with something in the hospital industry called the 72-hour rule. Anybody here encountered the 72-hour rule? 72-hour rule is, if you are in an intensive care unit for 72 hours, there is an automatic review that is triggered with your doctor and with other healthcare professionals to understand what it is that's going on with you, to make certain that the health care that is being provided to you is not quote unquote futile. Sarah Palin had a different word for it. We're not talking about that. In fact, I'm sorry I even brought up that woman's name. Palliative care is not something we need to be afraid of. But up until 2 years ago, here's something you need to understand. Up until 2 years ago, palliative care was not something that over half of the hospitals in this state did. Okay? And so we spend a heck of a lot of money at the end of life in providing care that arguably is futile. And so we've got some forces at play here that's been stimulated by this change. It's not, there were those who said, what would happen if the Supreme Court had overruled the individual mandate? It would have been horrible for insurance companies, which, why do I care? I really don't. But it would have ruptured all of their underwriting policies and made it impossible pretty much for them to let insurance. But it really didn't mean much as far as the forces that were set loose by the ACA. Commercial insurance companies had already begun to change. They understood that it was okay to have narrow networks, meaning that we're not going to have every doctor and hospital provide care to you or be available to provide care to you. What was not acceptable in managed care back in the 80s, all of a sudden with super managed care now is acceptable. Back in the 80s, you would not have accepted a health plan that said you could not go to Cedars if you happen to live in Cedars catchment area. You would not accept that. Today it's acceptable. Cedars does not have to be in every, and I'm not picking on Cedars, I can pick at Huntington, any high quality, and Cedars and Huntington are very high quality hospitals. But that doesn't, but they may not, the cost of care may not fit in the profile any longer for certain insurers. And that's the type of thinking that's going on now. And that's what's driving a huge change in this paradigm shift that we see occurring with healthcare reform. Thank you.
So I'm going to talk about, one of the things that, I'm going to talk about two things. One that's totally in the news, where everybody's talking about whether our bodies have magic powers. And whether a bunch of men should be able to decide if a woman's been raped or not. So there's a lot to talk about that. But I also want to talk about Medicaid. One of the things that was almost never discussed in the whole healthcare debate was the expansion of Medicaid and what that would mean for low-income people. Oh, I'm sorry. Hello? Yeah? Closer. Closer. Okay. That works? Sorry. Okay. So I want to talk about three things. I want to talk about what healthcare reform and Medicaid expansion means for low-income women and families. Access to preventive services and wellness, and reproductive health, and do all that in 4 minutes. And just to give it some context, 24% of the women in California are uninsured. I mean, that's huge. And for women of color, we're talking about 38% of African American women, 38% of Latinas, 26% of African American women, 17% of Asian Pacific Islander women, compared to only 14% of white women. And obviously there are tremendous links between poverty, health disparities, and access to insurance. So we know that for women of childbearing age, African American women are 4 times more likely to die from pregnancy complications than white women. We know that Latinas experience twice the rates of diabetes as white women. So when we think about, women's health and the health of our communities, access to really comprehensive health care obviously is critical. And my big caveat is that the Affordable Care Act is a lot of wonderful things, but provides health care coverage, and we should never confuse coverage with access. Yes. So I want to be really clear, insurance is not access. We need to look at both of these things together. So it is not enough to be poor to qualify for Medicaid, which in California is called Medi-Cal. And you also have to fit in a category. And while everybody's talking about our magical parts, we often talk about bikini medicine. In other words, low-income women get health care sometimes based on what's covered by the bikini, right? So breast and cervical cancer screening and treatment, family planning services, and you qualify for Medicaid if you fit in a category. And that category is linked to childbearing. So poor, single, childless adults do not qualify for Medicaid. It doesn't matter how poor they are. And this is dramatically changed by the Affordable Care Act. And if there's one thing that was so shocking and appalling about what the Supreme Court did was it, on the one hand, upheld the individual mandate, but on the other hand, really put in question what will happen to the Medicaid expansion. Right now, the way Medicaid is set up is Medicaid is actually a voluntary program. States do not need, they are not required to participate in Medicaid. And in fact, the Heritage Foundation several years ago put out an analysis encouraging states to withdraw from the Medicaid program. Somehow the fact that the funding for Medicaid is a partnership between the federal government and the state government, and the Heritage Foundation was arguing that just on the state share, somehow, I guess all those poor sick people would go to Jim's hospitals and have to be treated as charity care, but was really encouraging states to withdraw from the Medicaid program. But all states participate in the Medicaid program, and if you do participate in the Medicaid program, you have to play by the rules. So there are federal and state rules as a condition of getting this money. So one of the new rules, and the way Medicaid works right now is the income eligibility for Medicaid is literally all over the map. So my colleagues say if you know one Medicaid program, you know one Medicaid program. Every state is allowed to set within certain boundaries its own income eligibility standards. So in a state like Indiana, you qualify for Medicaid if you earn 27% of the federal poverty line. That means if you make about $3,000 to $4,000 a year, you may earn too much to qualify for Medicaid. So what the Affordable Care Act does, it raises across the board all states to approximately 138% of the federal poverty line, which is about $30,000 a year for a family of four. And it gets rid of the categories. So if you are, if your children are grown and you're not old enough for Medicare, you could qualify for Medicaid. If you are a single adult, you could qualify for Medicaid. If you are not disabled, so if you are a person with HIV but you're not so sick that you're disabled, you could get preventive care and ongoing treatment through the Medicaid Act. What the Supreme Court said was this new rule is coercive on the states. And therefore, even though it's still mandatory, the remedy for a state that didn't expand its Medicaid program or doesn't play by the rules has always been the federal government can pull its federal funding. The federal government has never, ever, ever, ever done that, but it's on the books. So the court said that would be really coercive. And so at a practical level, the Medicaid expansion now, a state can choose whether or not to expand Medicaid. So you have Governor Rick Perry saying that Texas is not only going to secede from the union, but it's also not going to do the Medicaid expansion. You have other governors, how much is this about politics until the November election? It's hard to know. But in California, we have a deep commitment to expanding the Medicaid program. So we are going to, we have legislation making its way through our legislature right now. So what will happen for women in particular? The Affordable Care Act, first of all, guarantees access to a whole range of preventive services without cost sharing. In other words, you don't have to meet your deductible, you don't have to pay a copay, you can get a cholesterol screen, not just for women, you can get a diabetes screen, you can get screening for depression, but the big firestorm right now is about the fact that you can actually get contraception. there are 27 states that require, including California, we are leaders in many ways. There are 27 states that require insurance companies to cover contraception, but that means that there's a whole bunch that don't. So the Affordable Care Act makes contraception available, and it started 2 weeks ago. So starting August 1st, when you either get a new plan or in your new plan year, and there are some exceptions, you are now eligible to get all of these preventive services without cost sharing. Another thing the Affordable Care Act is it requires coverage of maternity care. Now that seems like such basic health care for women, but the reality is up until July 1st in California, individual health plans did not have to cover maternity. And in fact, pregnancy or maternity could have been a pre-existing condition that could keep you from getting health care at all. So California took the first step to require plans to cover maternity services, and that's also a step ahead. The rest of the country in 2014, health plans will have to cover maternity coverage. No more sex discrimination in healthcare, no more gender rating, no exclusions for pre-existing conditions. All of this is critical to women's health. But what about other aspects of reproductive health? So we're really lucky to live in California. Because the Affordable Care Act, during the negotiations, they really tried to ban abortion coverage altogether. And you should know that the vast majority of health plans in the country cover abortion, and including in California. But they couldn't quite get that banned, and our friend Representative Ryan was one of the leaders in that. And so we got something that was called the Nelson Amendment, named after Senator Ben Nelson. And basically, it was an attempt to make abortion coverage as hard as possible. So abortion coverage is not, there's a lot of chatter about this, is not banned in the Affordable Care Act. It is not limited to rape, incest, and saving the life of the woman. Straight out regular abortion coverage is available under the Affordable Care Act. Now, states can ban it if they choose. So there are 20 states that have banned it altogether. But again, not California. And so there just are special rules. The insurance companies have to segregate they have to charge everybody $1 because abortion coverage actually saves money. And a lot of the provisions in the Affordable Care Act are based on actuarial value, and they didn't actually want the actuarial value. In other words, what's the actual cost of abortion coverage, because then everyone would get a refund. So instead, they make sure that everybody has to pay $1, and insurance companies have to segregate that money. So they have the abortion pot and they have the everything else pot. And the insurance commissioner is the one who's responsible for that. So here in California, we have Dave Jones as our insurance commissioner. Yeah, you're not kidding. I'm nonpartisan. But he's already elected, and he's very committed to making abortion coverage easily accessible, easy for insurance companies to cover it, easy for people to pay their $1, make it easy for consumers. So we will, in California, have abortion coverage.
Okay, why don't we, I don't want to get too deeply into all the details all at once, but one thing that I do want to ask the panelists to talk about is the issue that really is, I think for many people, the ball game. And that is, how do we, the term has been the cost curve, but really is how do we start reducing the growth of medical costs. Now, there are provisions in the Affordable Care Act that purport or are designed to do that. There are also conditions that are encouraged by the Affordable Care Act that are designed to do that. And then there are things that the Affordable Care Act could have done that it doesn't do that may have had an effect on that. So I'd like each of the panelists sort of briefly to talk about some of the provisions in the Act that either will help reduce the growth in costs or should have, and we can talk about Jim Lott talked about comparative effectiveness. This is a notion that's been around in the healthcare community for a long, long time. As he said, I think there was a provision in the stimulus bill for that. There's also a provision in the Affordable Care Act that's for a board called IPAD. The meaning of the acronym escapes me for the moment, but this is a board that's been set up that's designed to look at rising costs in Medicare and to come up with ways to address it. I think a package periodically that would have to be voted up or down by Congress all at once. There's the issue as to whether cost shifting is going to be reduced enough by the ACA to affect the overall cost of healthcare. And then, of course, there is the element that Paul's talked about, that it does install an even more central way as before the commercial health insurance industry in the delivery of our healthcare, and what will that do? So why don't we sort of each of you take on that issue, and I'll start with Jim, in part because there is a request from a member of the audience, and I think several would like to hear it. If you could repeat the title of that Wall Street Journal article that you referred to,
Sure.
so that people can look it up, and then go on to talk about
The article was dated December 12, 2011, and the title is "The Future of U.S. Healthcare," and the subtitle is "What is a Hospital, an Insurer, even a Doctor? All the lines in the industry are starting to blur." It was written by Anna Wilde, W-I-L-D-E, Matthews. So I think if you Google her or Google the article, you should be able to get it. It's a very well done article. On the question of cost containment and reducing costs, first we need to make certain we understand what we're talking about. In my view, there are two buckets that we put healthcare costs in. One is per capita cost, the amount that it costs to provide healthcare on average for every person in the United States, versus what's in the other pot, which is aggregate cost for treating the entire population of the United States. We are, and the two work against each other. We are a society that is expanding and that is aging. And so there's going to be increased costs that just will naturally occur regardless of what you put into place. When you have more people and older people, more people in society that's going to access the health delivery system, and where you have older people who by definition bring conditions with them that need care. So when you look at the way our population is aging, you're going to see just that cost. Now the per capita cost though is it reflects the efficiency in the care that's provided to people in a society. And we should be able to reduce our per capita cost per person in this country, and I can't remember the exact dollar amount, but it's like $2,000 to $2,500 more per person than the next highest country. And Dr. Song may have a more recent figure on that than I do, or anybody else on the panel might as well. So we need to figure out how to be more efficient. Now what the healthcare reform law does is it puts, first of all, it changes, as I mentioned earlier, the paradigm. We need to do more prevention of front healthcare, pay primary care doctors more, which it proposes to do, get the patient involved more in health education, wellness, health promotion, risk reduction, prevention, treat care on that end so that we can reduce chronic illnesses and other types of problems they're having. So it rewards and promotes that side. On the delivery side, what it says to doctors and hospitals and clinics and others is come together and share. We're going to give you an incentive. We want you to take care of the patient in a holistic way. And so we're going to do two things. We're going to let you go at risk for profit if you come together in organized delivery systems and provide care in an effective way that reduces costs. And you get to share in those savings. That's kind of what an accountable care organization is. It also says to hospitals the other way, we're going to give you bundled payments. We're going to give you a fixed amount of money to do a certain thing, or take care of a patient, and That means the whole pre-hospital, post-hospital, hospital and post-acute care, and you get to save, you get to share in some of the savings if you help to bring those costs down. So it's providing incentives through those two specific methodologies of bringing costs down by rewarding providers for providing care in a more effective manner, and then it also promotes prevention, wellness, health promotion, risk reduction.
Okay, thanks, Jim. I just want to say before we continue on with this question, I'm drawing a tremendous amount of heat from the audience right now for having cut Susan off. I want to assure everybody that I will let her finish her thought. But let's continue just right at the moment on this particular question, and then once the other panelists have had their say, we'll come back to Susan.
I just want to say that with regard to costs, we have data on how this is going to play out, and that's in the state of Massachusetts that has been doing this for years. And their costs have still continued to skyrocket. They've insured 99% of their population, but they've still not reined in costs. You can nibble around the edges with the accountable care organizations and as such, but until you rein in the real drivers of costs, which are pharmaceuticals, which were negotiated out of this in the very beginning, and then we can't lose fact that for every dollar that's spent on healthcare, the private insurance industry takes 31 cents of that dollar away. They used it to pay for overhead, sales and marketing, lobbying, billing, and underwriting. That's the biggest driver of cost that could be really brought in. In the state of California, I think when you started with managed care, there was a need. There were a lot of doctors that were ordering unnecessary tests. They were doing a lot of fee-for-service, and there needed to be some accountability. So what you've done is you've cut all of that excess fat out of it. But then when you've cut all that and made it more efficient, the costs have still gone up. So then you start cutting into muscle and bone and critical services for people. And I think that there's a lot to be learned by the Massachusetts model. You did have the closest thing to universal coverage, but if you really look at the analysis, their costs have continued to skyrocket, and there's nothing in this provision that really will rein that in. Even the most optimistic people believe that costs are still going to go through the roof. So that to me was a big fallacy that was perpetuated during this debate.
Trying to do a few things very quickly. One is Massachusetts actually didn't have any cost containment provisions in the plan, as in zero. And it was all focused on expanding coverage. Now Governor Duvall is working on cost containment provisions that may or may not work, but the Massachusetts plan was never thought to save costs. And the ACA is different in the sense that you take every single idea that anybody's thought of in the health policy community, it's somewhere in there. Most of it in the form of pilot and demonstrations, the ACAs, the medical home provisions, bundled payment, all these other things. And we don't know whether they're going to have much impact or when they'll have impact if they do. There's a lot of experimentation. Clearly the best way to control costs would be to meet the international standard, which can be done in lots of different ways, but one simple way is a single payer system. Then you budget it, and you budget the whole system. And that would be the most effective way to deal with costs, but we're going a long way from there. Well, let me just say one more thing about these various experiments and why they're there, and including the discussions of comparative effectiveness analysis and PCORI, which is the Patient Outcome Research Institute that was set up, and the Centers for Medicare and Medicaid Innovation Center that's now giving out millions and millions of dollars in this effort to try to find innovations in the context of this existing arrangement. And that is, for years, back when I was working in the Senate in the early 1990s, everybody was talking about how 30 to 40% of the money that we spent in the system is wasted. We could get rid of it and have higher quality care and cover everybody. Problem is, nobody knew what that 30 or 40% was, where it was, who was doing it. And we know from the folks at Dartmouth, the very famous Dartmouth Atlas, which, and others who've worked on it even a little bit further, that there are huge variations in medical practice in the United States that apparently have nothing to do with the conditions that the patients are presenting. They have to do with the nature of medical practice. Go to McAllen, Texas, if you really want to spend money on healthcare. It's the most expensive place in the country without any clear health benefits. So we know there's a problem in the system. We know we can get greater efficiencies and produce higher quality care. We just don't know what or where or how, and that's what this experimentation is about. But that said, in the end, and this may be what ultimately drives the system, say 20 years from now, is ultimately the way to wrest control is to have a budget. You can either do that through single payer, or you can do it like the German system, where you have a government orchestrated system of payment. It doesn't have to be tax financed, but one way or another, you need a national budget. And one last thing, when Representative Paul Ryan is talking about wresting control over the costs of Medicare and controlling healthcare costs, they are really talking about controlling what the federal government spends, not what the actual per capita costs or aggregate costs of healthcare are overall. And one of the questions Americans have to face is it so important to keep that system in the private sector if in the end what we really care about is optimal health, optimal life, optimal quality of care at the lowest possible cost? And we don't have the mechanisms to get there with what we've structured, but we do have some mechanisms to at least start doing potentially some useful innovations.
I just want to add something from a consumer advocate perspective, which is we are trying to create a system where we are going to try to bring in people who are low income, who have not had access to care, who we know have delayed getting care because they can't afford it. And we have to have a long view and not be sidetracked by the idea that healthcare costs probably are, in terms of state and federal governments, are going to go up in the short term, because we're going to bring people who are sicker and need more into the system. And I just, imagining the Wall Street Journal headlines, as the Affordable Care Act goes into effect and these public costs go up. And I think we have to remember that we have to have a long-term evaluation, not a knee-jerk reaction that I'm sure we're going to hear.
Now go ahead and finish your thought.
I just want to say, all right, I'm just going to say one more thing. And it's about access, the difference between access and coverage. And that is that how important, one of the things that, because we're all going to have managed care and how managed care is going to work, and Jim mentioned it, this issue of what is the network adequacy. And I want to raise it in the terms of women's health and access to comprehensive reproductive health care. Because we know that, for example, in California, where we think that abortion access is plentiful, that more than 50% of the counties in California don't have an abortion provider. We know that Catholic healthcare systems are the largest systems in the state. We know that 18% of the hospital beds in the country are in Catholic systems that will not provide a whole range of reproductive health services, even in emergencies, or there are no exceptions for rape, incest, and to save the life of the woman. So as we develop our system in California, and that NCJW, this is the important part I wanted to say, has been an important ally in advocacy in California, we have to be making sure that access is real for women, and that we have standards that look at what services are actually available, not just counting numbers of hospitals or numbers of providers.
Okay, all right, thank you for pulling my fat out of the fire. We've talked a lot about, we've just talked about the overall cost of healthcare. Obviously there are provisions in the ACA for the individual cost of healthcare and health insurance, and we've gotten a number of questions from the audience about what is in the Act or what is in the system that's going to help people afford the care that's being made available. This is the question that Susan talked about, of not only coverage but access. Maybe you could each sort of take this on. What is there that's going to help people afford the care that's being provided? And that also sort of gets into the issue, an issue important in California, or on the table in California, which is Commissioner Jones's efforts to get prior approval authority on health insurance rates, as he has for auto insurance and home insurance and property insurance. He wants to be able to approve changes in in healthcare premiums as he does for these other things. There are provisions in the Affordable Care Act that limit the range of premiums, I believe, that insurers can charge based on certain factors. How effective will that be? What else needs to be done? And what provisions are in there to enable people who may not have the resources of employment or well-paid employment to afford it.
Let me do the easy part.
Sure, all right.
The easy part is, again, I'm going to give you another citation. Go to the Kaiser Family Foundation website, kff.org, and look up the ACA, and you can get a very good summary in English that explains simply what the provisions of the Act are, by section. And so you can look up the answer to the question that was just asked. But anything else you might want to know, it's a very, very good source. KFF.org. So please go look at it if you don't have a good summary of the Act. But the first part of the question was what's going to help people. The Act requires everybody, as you know, to have health insurance. And the test for that is going to be through your income tax filing. If you make between 138 and 200% of the federal poverty level, there will be a graduated scale. 400%. 400%. I should let you answer the question. 400%. There's a graduated scale of a subsidy that will be provided to help you afford to buy the premium. If you need to get an individual policy. There are also incentives in it for small businesses or for businesses to also provide insurance. But go to the Kaiser Family Foundation and get that. You can get a very good summary of that.
The problem with there's a problem with the Supreme Court decision regarding the Medicaid. So Medicaid gets expanded to 138% poverty level, and the original plan, out of the 51 million uninsured in the United States, 32 roughly million were going to be covered by this. Half were going to be covered by the individual mandate, and half were going to be covered by expansion of Medicaid. So now, if you look at the 20 states that are kind of not sure if they're going to participate, you're leaving a lot of people that don't fit into either, and they're kind of lost. And they're not going to be technically covered by the Affordable Care Act. So that's a question of what's going to happen to those people. I recently met with Dave Jones, and for any of you who are interested, I'm actually having an event for him on Sunday. But to talk about specifically California, as you know, there was a there was a bill in the Assembly, AB 52, which would have given him the rights to regulate insurance rates. And one of the things with the Affordable Care Act was it changed something called the medical loss ratio. So what I was mentioning before, where the insurance industry takes currently 31 cents away of every dollar out of actual patient care, the medical loss ratio has made it 85 cents of every dollar now has to be spent for individual plans on actual health care, and 80% for people in group plans. So roughly still they're able to take 15 to 20 cents of every dollar away that could be used for patient care. What Dave Jones pointed out to me, it was very savvy, that doesn't sound as good because while they can only keep a certain percentage, it doesn't allow them from charging more to make up the difference. And right now, because he's powerless, he doesn't have the right to regulate those rates. And I hope at one point we can. You've heard certain people mention single payer. I just want to briefly say one thing about that. I think a lot of what was said is true. Politically, it may not seem like there's an appetite for that. But there have been recent polls where the majority of Americans are interested in a Medicare for all system. All the doctors in Massachusetts universally support a Medicare for all. What is going to happen, though, it's going to happen on a state-by-state level. The state of California, we narrowly lost this debate last session when we lost in the Senate by 2 votes. Despite, we had 6 Democratic senators who either didn't vote for this or abstained from voting, and they turned out to get the most money from the private insurance industry in the state of California. If you go actually to Rod Wright is one, Hernandez is another. I can email you that. But here's the issue with this. in the state of California, one thing that the Affordable Care Act does allow is grants waivers to states to opt out. One of the things people say is that California is bankrupt and we can't sustain it right now. There is a kind of a perfect storm brewing in the U.S. Congress right now. A lot of Republicans you hear will give block grants to the states, right? That you hear that, and let the states decide what they want to do. Be careful what you wish for, because Jim McDermott, who's trying to put a bill together to allow these block grants to go to states so that the money that goes for Medicaid, Medicare, S-CHIP, all of that could be used to establish a healthcare system. If you have something like that, you could really have the capital to establish a single payer system in the state of California. And how that works is that 31 cents that's currently wasted would go back in to cover the system. So there would be a truly pure, not-for-profit system. And in doing that, there's been a lot of studies in the state of California that have showed the California Nurse Association said that that would create 2 million new jobs. The California Federation of Teachers said just their healthcare bill alone would be reduced by $300 million a year. Think of what a stimulus that would be to our economy. So one thing I would urge you to do is to go to our website, www.pnhp.org, to learn about what real single payer is, because we really need to start this on a grassroots level. By eliminating that
website,
www.pnhp.org. And there's several things. One is eliminating the administrative waste. The second thing is negotiating bulk price purchasing. So what we were unable to do is negotiate drug prices because of the deal that the administration made with Big Pharma. But then you would be able to have cost savings in terms of that. You would actually, doctors would actually have one form to fill out, and their administrative costs would be reduced by $70,000 a year. There are a lot of real advantages to a single payer system. It's more efficient. And countries like Canada actually the doctors there are actually happier than they are here in the United States, and so are patients. So sorry to hijack the mic, but I felt like I wanted to at least get that point out, because you're going to hear that it's politically unrealistic. Nationally, yes, but on a state-by-state level, we're 2 votes away from getting SB 810 passed in the state of California, and Governor Brown had said in the past that he would sign that.
So I'm just going to add, I'm sorry, I have to respond. We get different opinions here, it's important. A single payer system would be incredibly important here in California. The block grant concept would be devastating for low-income people. We have experience with Medicaid block granting low-income programs. We've seen waiting lists of tens and hundreds of thousands of children trying to get into the Children's Health Insurance Program, both here in California and in other states. We know that we have a block grant, for example, for HIV drugs, and that there are thousands of people on waiting lists because the needs are always greater than the amount of the block grant. So I just have to push back. I know there are people from California advocating in the Congress to block grant these programs, and I think it would be disastrous for the very programs that people are trying to save.
I just want to say, I absolutely agree with you, but the stipulation in the Affordable Care Act is you can only use that and get a waiver if you meet basic minimum requirements. In the past, block grants did not have any provisions in for that. So I absolutely agree with you on that.
It obviously depends enormously on what the Congress is like over whatever period that is done. And the next Congress and the next House and maybe the Senate are not likely to block grant very effectively. But I'm always torn on these things because I am a single payer supporter. I help write a bill on single payer. I would love to see single payer. I'd love to see California do it. I love all those things that move forward. And it's extremely important to have people like Paul who are constantly pushing on this and saying, stop telling me it can't be done. It's important, it's worthwhile to do. At the same time, one has to have a certain amount of political realism, or else you end up with potentially nothing in between. And this is a huge struggle both at the state level and at the national level. But it is, and we do recall, single payer has been on the ballot, I think, twice in California and got devastated each time. So it's hard to recall that there are people outside of this room who actually don't like these things. We tend to like them a lot, and then we forget about the others. Let me just say a couple things. One is, I'm going to be a little bit out on a limb on the Medicaid issue. I was disappointed in the court's decision on the Medicaid expansion. and the court striking down the fact that the federal government could withdraw all Medicaid funds from a state if it chose not to do the expansion. That being said, I am a political scientist, and Susan already said it, the federal government has never withdrawn Medicaid dollars. No federal government is going to go to the state of Georgia and say, well, you're not going to play? Well, we're going to take away all of our money, so all your poor people get no health insurance. And so my sense is that this will be less significant than it seems. That it would, that the federal government would never have used that baseball bat loaded with lead weights, the so-called nuclear option anyway. And frankly, I would like to be the opponent to the governors right now who are saying they're not going to take the money. I think that's going to be a political loser for them in the years ahead. So I'm a little more optimistic about this, even though disappointed in the court's decision. Back to the original question, one thing I did want to throw in is the worst part of the American insurance system is the individual market, where people either can't get insurance or they have to pay enormously high rates of insurance. There's medical underwriting. Everybody is his or her own risk pool. One of the things the Affordable Care Act does is get rid of the worst part of the commercial insurance industry, and that is the individual market, and pools that population into state-level exchanges so that you have real opportunities to bring down the costs, and also it gets rid of medical underwriting in a variety of ways in which there's going to be a segment of the population that's going to have access to insurance, affordable insurance, in a way that was just never possible. So there is that element that's going to affect some people in some pretty serious ways.
Okay, thanks. We have about 10 more minutes left, and we have a lot of questions here that unfortunately we're not going to get to. And what I would like to do in any event is ask each of our panelists to sort of give a couple of minutes of thoughts to wrap up the discussion we've had and some of the things that we've heard and talked about here. I would say one thing that we have a lot of questions here, and you might want to think about whether this is a theme you want to touch on in your closing remarks. A lot of questions about whether we are going to have enough doctors in the country to serve the surge of patients coming in. Also about whether we have doctors in the right place, and that is the realities of medical education, the cost of medical education, the debt that young doctors emerge from medical school with. Are they not steering doctors into narrow, lucrative specialties? Well, what we need are more GPs, more family physicians, and so on. In other words, what does the ACA do, or should it do, to address whatever imperfections we already have or may continue to have in our system of medical training and education and distribution? So why don't we start? Each of you take a couple of minutes to wrap things up. Paul, why don't you start?
First and foremost, I think that there is going to be a doctor shortage in California and also nationwide, particularly doctors that are educated in the United States, and nothing to take away from foreign medical grads, but just the number of doctors coming out is decreasing. There was a 10% raise in the Affordable Care Act that's already been implemented for primary care physicians, and they're really the crucial gatekeepers: family practice, primary care, internal medicine. What's happened is a lot of people have gotten discouraged with the average medical school debt when they graduate is $200,000 just from medical school. And then on top of that, you add training and having to pay off student loans and high malpractice costs and decreasing reimbursement. People that go into medicine really have to love it and go into it for the real reasons rather than anything else, because if they want a 13% tax rate, they need to go into finance. I just want to say this. I happen to be luckily born the same year that Medicare was introduced, and I just think that having seen that patients, I treat patients with Medicare, Medi-Cal, the Medicare patients truly have it the best. And as a physician, we enjoy dealing with Medicare much more than the private insurance industry. It's less bureaucratic, much more efficient, and our patients are much more satisfied. So whatever you may hear, it's very different. I think that ultimately we will get there. It may not be for another 10 years or whatever, but I remain optimistic that we have to, because that's the only sustainable system that our country can afford. I just want to add, one of the things that's damaging in the Affordable Care Act is that, you hear this debate going on between Paul Ryan and the Obama administration about Medicare cuts. Where President Obama's cuts are really coming from are not for benefits for any of you, but it's coming from waste, but also cuts to hospitals and physicians. And my concern about that is, look, there are doctors out there like myself, we'll treat anyone regardless of what the insurance status is. But you're going to see more and more doctors who are going to stop seeing Medicare patients because the cuts are going to be possible. And that's the only downside to that. So that is something that I am concerned about with the Affordable Care Act. I think all in all, the more people we have insured is a good thing. I tend to be extreme at these meetings because I want to point out that I think we could have done so much better, but I do think this was a starting point, and it's better than nothing, and dramatically better than nothing. So with that, thank you.
Jim, why don't you pick up
I agree with Paul and everything that he said, quite frankly. I do think, though, that with regard to the physician shortage, we're going to have to be creative. We're going to have to be inventive. We're going to have to think out of the box. You've heard those cliches before. We are not going to be able to move fast enough, quite frankly, to keep up with the doctor shortage. We're not going to be able to move fast enough to bring down the price of education to get more people, the cost of education to get more people to go to medical school. We're going to have to, if we want to meet the needs of a population that's expanding, that's aging, that's demanding more health care, we're going to have to utilize physician extenders more to the fullest extent possible. We're going to have to look at scopes of practice, laws, and regulations, and begin to allow nurse practitioners, physician assistants, other classified allied health personnel do more in the primary care field. The ACA was a good start with the boost that it made to primary care physician incomes, but it's not fast, it's not enough, and it's not fast enough. And we're going to have to start looking at these other people who are capable of providing health care to a greater extent than they're currently being allowed to, largely because, quite frankly, I'm going to be honest, I'm just lay this out on the table. In California, organized medicine is our worst enemy when it comes to that. Okay? And if we had more time, if this was the start of a panel discussion, I'd tell you more about why that's the reason. But it's the end, so I'll just leave you hanging.
And so as long as Jim spoke about letting allied professionals do more, I'm going to put in a plug for AB 2348. You can call your state senator right now, and that would allow nurse practitioners to actually prescribe birth control. Radical. What I want to say in wrap up simply is I loved the opening ceremonies at the Olympics, the way the British celebrated the National Health Service. And all this, the conversation that we're having about costs and what it costs and whatever, we have a responsibility to shift our national conversation to looking at healthcare as a public good.
Yes.
And that is where this conversation has to go. And I'm very optimistic that the idea for me that 50 million people will at least have access to insurance is the right step. And we have a lot of work to do.
Thank you. First, just in response to the issue about doctor shortage, everybody said, yes, we're going to have a doctor shortage. And it's going to be made, quote unquote, worse by having the ACA expansions. It's sort of like the question or the issue that people say, well, we can't afford healthcare reform right now. What do you mean we can't afford healthcare reform? We can't afford not to have healthcare reform. It's not like we just say to people, excuse me, just buy fewer CDs for the next few years. We're talking about people's health. They're not going to go anywhere. They're still going to be sick. They still are going to need treatment. And they should have treatment earlier rather than later, should have the right treatment at the right time. So the notion that we can't afford to do it or we can't afford to do it because we're not going to have enough doctors is a kind of perplexing way of approaching it. We're going to have a lot more incentive now to create more expansions. And among physicians and, importantly, to the non-physician kinds of providers. I want to close, though, with the notion and underscore this. Just as when Medicare was passed when Paul was born, it didn't look like anything like what we have today. It was an open door to the federal treasury for doctors who set almost whatever fee they wanted to charge. It paid hospitals whatever hospitals said it cost to treat a patient. It was, we didn't want to besmirch doctors by having them have to deal with public bureaucrats, so it all uses fiscal intermediaries from the private sector to actually do the processing of the paperwork. Medicare is fundamentally different today. We have a prospective payment system for hospitals. We have a Medicare fee system, the RVRVS. I won't tell you what that all means. For doctors, we have all kinds of innovations. In fact, Medicare is often leading in innovation in the health sector, not the private insurance industry. The private insurance industry is often picking up the Medicare innovations, not something here typically in the United States about where innovation comes from. It was a start. Medicare was a start. The government took on a responsibility. That responsibility had costs. The costs led to incentives for the government to do more, to take on more in terms of innovation and broadening. The ACA is going to be similar. It's not the end of it's not the beginning of the end. It's the end of the beginning. It is a platform. It's a platform we're going to build on one way or another and may ultimately replace as we go down the road. And one thing that we can do, there's no reason why, given the next political circumstances that are conducive and a little experience, have a public option. Return to that issue. Have experiments with public options. Give people more confidence in that kind of approach, which again may feed a pathway down the road. So we've got to be very careful. This is not the end of the discussion. It is a ratcheting up and creating a platform for a very different discussion than we otherwise would have had about healthcare in the United States. In the meantime, a lot of people are going to get health insurance coverage. A lot of people are going to have more affordable care. They're going to have greater access. We're going to have more innovations going forward. So I think if we think of it in those terms, we can be more optimistic. But it has to stay in place. So the first thing has to, I don't want to be partisan about this, but the parties have given us the choice. If you think there ought to be a government role for broadening the base of insurance coverage and access, if you think the ACA should stay in place, I don't have to tell you what the outcome is required in November to ensure that happens. I just want to say thank you. This audience reminds me of an African-American Southern Baptist church. The amens and yahas and yeah, go brother. So this was real great fun for all of us. Thank you very much for having us.
And can I just say one thing? I just want to, for those of you, I'm sure everyone here reads Michael, but for those of you who have not, I encourage you. He is one of the sane, reasonable voices in our state. I think more people need to really read what he writes.
Well, thank you, and I wish everybody who emailed me would have the same sentiment. Anyway, I would like to thank the panelists. This has been a fabulous panel. Questions from the audience have been terrific, and I apologize that we were not able to get to all of them. And just a couple of quick words from myself. First of all, I think it's clear, and I hope I'm not being too presumptuous when I say that, it certainly looks like from what we've heard today that the presidential election is really going to be a test of the question of whether Paul Ryan and Mitt Romney can win office without the votes of anybody in this room. That may be presumptuous, and if it is, sorry. But I want to endorse something that Mark said, which I think sort of does sum up what's been said up here on the dais today, which is that I think everybody here, certainly everybody on the panel, and I think most of you in the audience, really expect and hope that the Affordable Care Act is not the end of the discussion, but the basis for a continued discussion, and that we hope it doesn't close off options that we need to look at in this country for the fair and just delivery and effective delivery of health care. The way the health care delivery system has developed in this country over the last 20, 30, 40, 50 years has been a global scandal. I think everybody understands that. And it's taken that long for the government, for our leaders in Washington to address that, and they at least have started it, and let's hope that it hasn't been finished. Once again, thanks to all of you for coming. It's been a great discussion. It's been
On behalf of NCJWLA, I want to thank everybody on the panel. This was excellent. We all got a really good education, and that was what I was hoping for. And I want to thank everybody for coming.